like to go ahead and call to order the July meeting of the Board of Commissioners. Any points of order? Hearing none, we'll move on to item number 2, the consent agenda.
Move approval of the consent agenda.
Second. A motion and a second to approve the consent agenda as presented. All those in favor?
Aye.
Opposed? Motion carries. Mary, you're up. We have a Moss Adams presentation. Are you going to be using?
We are, yeah,
Okay.
sorry about that.
No, that's fine.
Yeah.
He's not here. Oh,
Good morning, everyone. We're here to provide a recap of the audit results for 2014 for Whidbey. We've gone through the same information with your finance committee, but we'll be covering some of the highlights there for the important board communications. We'll go over also a few of the financial recaps and highlights from the last year, and this is the year ended December 31st, 2014. Paul Holden is here with me today, and he'll provide some of the observations from a critical access hospital standpoint. And then we'll wrap up with a couple of national industry observations. So these were the important board communications that we covered when we were here in June and issued the final financial statement. It was an unmodified opinion, which means it's a clean opinion, best opinion you can have. The other bullets here cover some of the other required communications that we cover at the exit of every single audit. A non-attest service update. A couple of the items there to note is that we are involved in doing some other work for the organization in addition to the audit work. A few of the things that will be going on very soon is construction audit work as well as cost segregation work related to construction. Important to note here that there were no audit adjustments during the audit process, and all of the significant accounting estimates were deemed reasonable. The most significant of that of those estimates in your financial statements is the allowance for doubtful accounts on your accounts receivable. Another important board communication is the results of any internal control related matters. Good news there is there's no material weakness identified in 2014. There was one significant deficiency, and it's an area to pay attention to related to reliance on spreadsheets and just increasing the level of mid-level review of reconciliations and estimates. So the recommendation there is just to make sure that there's adequate staffing and the resources necessary to be able to take care of that mid-level review, and management has already made changes and put things in place to address that. So moving on, this is a recap of the financial statements. You can see the dates are a little cut off at the bottom there, but starting in 2010 on the left-hand side, all the way to 2014 there in the blue. So that's the year that we audited in the right there in the middle. What you see over to the other side is the Moody's benchmark information. So that's what a A-rated facility, a BAA, and an all-in number would be from a national perspective. Now, it should be noted here that that is hospitals that are very large in a lot of cases that are in this, so you need to make sure you understand that when you're comparing the different results here. I do have a couple of critical access hospital-specific benchmarks too that I'll mention as we go through these slides. So for example, your days accounts receivable, which as a reminder, this is on average how many days it took to collect your accounts receivable. That was at 42 days in 2014. That uptick in 2013 was related to your system implementation. Unfortunately, with every system implementation that we see with hospitals, you traditionally do see that it's going to take longer for a period of time to collect that receivable until you get the system completely in place. So good news that 42 days means your average is down, your cash collections are coming in better than in years past. To give you an idea from a critical access hospital standpoint how you would compare there, the US average for critical access hospitals is at 53. So being at 42 is a very favorable position for sure. Washington specific critical access hospitals are at about 55 days. So again, a positive point there that you're at that 42 mark. So average age of plant is the relationship between how quickly you're replenishing your assets versus using up via depreciation. So your results as of the end of 2014 is 11.5 years. And that trend down is, of course, related to all the new things that you're doing here with the organization with regards to the facilities. You can see where that compares to the Moody's in the red as well. And that will continue to go down with the new construction that you're doing. Again, the critical access benchmarks that are out here for US in general, it's about 9 years or almost 10 years on average. And in Washington State specifically, the critical access hospital average age of plant is about 11.8. So you can see that fluctuates pretty greatly between the national and the Washington stats. So moving away from the statement of net position and looking at some of the operations of the organization, this again shows from 2010 on the left-hand side all the way to 2014 on the right-hand side. The revenues are in the blue and the operating expenses in the red. So the total of those two together, your operating margin was a negative 6.1% this year. When you compare that to critical access hospitals out there again, this is 2012 information, so it's a little bit dated, but it gives you a little bit of a sense that unfortunately you're not alone in some of these cases with the margin. Washington State, for example, has a negative 1% margin overall for critical access hospitals. Nationwide too, even though there is cost reimbursement involved here, there's about 38% of critical access hospitals that are reporting a negative operating margin overall. So there's definitely continues to be some challenges there. So salaries and benefits, with every healthcare organization and hospitals especially, salaries and benefits is going to be the most significant portion of your operating expenses. So it's always good to understand how this relates to your operating revenue coming in. So you can see in 2014, it was at 58.2. Now, that doesn't look very significant as far as it changes over the year, but knowing that your operating revenue increased pretty significantly over this last year, the fact that you were able to keep that flat is definitely a significant item to note. So Washington hospitals, critical access-wise, just to give you an idea again on benchmarking, in 2012 it was at about 51%. The other thing to note here that we'd also talked about during the Finance Committee meeting is from an education standpoint, you need to understand when you're comparing some of these statistics to other hospitals, different hospitals have different strategies as far as how you employ versus not employ physicians. So this number is going to change depending on what your strategy is. So it's not necessarily a good or bad thing where you're at percentage-wise relative to the others. Most important thing is to understand what is an appropriate benchmark for yourself internally and to be able to track along with that. So I'm going to hand it over to Paul to talk about some of the national critical access hospital issues and switch places with me.
Thanks, Mary. In regards to critical access hospitals, something we're seeing nationwide is there have been some closures across the country in the last couple of years. As Mary mentioned, there are a fair number of rural hospitals that are running at a deficit. That's not uncommon, and it's not uncommon as compared to historical averages, because typically what we see in rural areas, if you're a district hospital, you may run an operating loss due to the patient care activity, but you have those ad valorem property taxes to make up the difference and to bring you back into parity from a net income perspective. The issue we're seeing with critical access hospitals, though, is as critical access hospitals have kind of become, I don't know, not necessarily in vogue, but back in 2003, when we really saw a lot of hospitals converting to critical access status, the federal government started to take notice of this cost-based reimbursement status that the hospital receives. In some ways, they feel that it's an unfair advantage, but certainly for where the hospitals are located and how the operations unfold for these types of facilities, this type of reimbursement is truly necessary to keep the hospital up and running. This fourth bullet point under the bad news piece, there was an exemption historically that if a critical access hospital could not become critical access under the federal criteria, which meant that it was 35 miles away from the next nearest facility, you could qualify under state statute that fell under this, what they call necessary provider status. Now, necessary provider status meant that a hospital who was within 10, 15, 20 miles could also become critical access. Well, in the state of Missouri, there were approximately 55 critical access hospitals, but almost 40 of them fell under necessary provider status. So the federal government started taking a hard look at some states in the country that had a lot of critical access hospitals, and were trying to find ways to maybe eliminate this in some areas. Now, for Whidbey General, we're not as concerned because there's not another hospital that's within a reasonable distance, excluding a ferry ride, for the patients to receive alternative care. And so we're keeping an eye on that as things unfold. Some things that we'd like to talk about on the critical access side going forward, and it's something that we worked with Frank Hemian on, who is the interim Chief Financial Officer, is when we look at the payer mix for Whidbey General, it's very much in line with what we're seeing with other providers. You're going to have your governmental contracts, Medicare and Medicaid. As we've seen in the last year or so, even Medicaid is evolving in the way they're paying the hospital. They have their traditional plans for Medicaid, but then they're also rolling out new plans that are meant to contain cost and start to emphasize more of a coordinated model with the patient. The commercial contracts evolve as employers are able to offer more or less insurance. And then Mary specifically works with the exchange here in the state of Washington. And as folks are able to get insurance coverage through the exchange, we're going to see the cash flow from patient care evolve as well. So on that second bullet point, that's why I emphasize that flexibility and adaptation really will be key to survival going forward. Management having the ability to hire or to seek guidance from outside consultants, to look internally and utilize the business office staff that the hospital has, really keeping up to speed on the way billing patterns are evolving, coding practices. We have ICD-10 coding coming online October 1st. That's going to be a monumental change in the way things are documented in the medical record. So really, it's an opportunity for the hospital to really take the system that's been implemented over the last couple of years and really put it to the test. You've spent the money to get your electronic health record system up and running. You have your GL system online. Now let's really see what this thing can do. And the most important thing is, now that you have this electronic sort of black box in place, you want to make sure that the information that's coming out is the best story possible, that it's not garbage in, garbage out. CMS and other regulatory bodies are really going to be looking to that data for the hospital to demonstrate what type of care you're providing. Are you doing it in a cost-efficient manner? Is it really in the best interest of the patient that you're providing an MRI or a CT service, things like that. And really the last point, and I've had the pleasure of working with Whidbey over the last year, we've definitely seen a lot of really great folks coming to the hospital, getting a chance to work with Jerry, and we're looking forward to working with Ron as well. And so really we're at a point now with critical access where while we still have cost-based reimbursement, as we're working with these new payment models, being nimble and keeping our heads on a swivel are going to be vitally important. So those are a few kind of perspective items that we wanted to share with you as well.
We'll move on here. Just have a couple more points to cover, and again, more from a national and a few points on the Washington state specific. So the Affordable Care Act, it's certainly so complex. It really is a big question as to whether it is truly working. So what can't be denied, though, is that it definitely has led to less uninsured. So we started out in 2010 with about 45 million in estimated uninsured. Right now, about 11.7 million people have selected healthcare policies or healthcare plans through the public exchanges. But the bigger story here is definitely in the states that chose to expand Medicaid coverage. That's the bigger story in all of this. Medicaid enrollment grew by over 8 million since the new Affordable Care Act went into place here. In Washington state specifically, pre-ACA Medicaid enrollment was about $1.1 million, or 1.1 million people, excuse me. Currently it's at about 1.6. So that's about a 47% increase, which definitely has an impact on all organizations across the state in getting that payment flow coming through, where previously these people would have been presenting as possible folks coming through without any coverage at all. So the key takeaway here, though, is that the purpose of the act is not necessarily to bend the cost curve on healthcare. It was definitely focused on bringing more people into the system. Another piece here too that should be noted is that the budget related to this, all of the cuts that were coming through to a lot of the hospitals was based on a certain population of people coming through the system with insurance or Medicaid coverage. Right now, we're at about 65% of that budget. So that means that the healthcare organizations overall have continued to feel the effects of the cuts that have come through related to this act. But the inflow of individuals coming through the system has not quite made it there. So it's definitely, it's hurt so far, and it's not quite penciled out as the government had hoped. Paul touched on quite a few of these points here with payment transformation. So you have more people in the system now, which is great. I think that's definitely a positive thing for those individuals as well as the healthcare organizations. But now what you're seeing is additional pressures on the healthcare spending, needing to work towards that flexibility to be able to work under a system that is going to be paying for outcomes as opposed to just the volumes. Paul also touched on providers are going to be pushed towards this point of taking on more risk. Now, the clarification here that also Paul mentioned was that as a critical access hospital, you're still cost-based reimbursed for Medicare, but the discussion is out there that maybe we will, in the future, work towards making some of the critical access hospitals a part of some of these programs like value purchasing, bundled payments, affordable. So that is out there, and some of those discussions are ongoing. And of course, with changes in Medicare, there's also going to be changes in the other commercial payers as well. So the key here is that the commitment to payment transformation, this has been a discussion that's been going on for a really long time. The difference here is that Medicare has actually drawn a line in the sand and said by 2016, we're going to 30% tied to these alternative payment models. So by 2018, we want to be at 50%. So again, as a critical access hospital, your cost-based reimbursed, so you have to understand that it's different as it stands right now for you versus some of these other hospitals. But things are definitely changing, and they're changing at a pretty rapid pace, or going to be changing at a rapid pace based on the rules outstanding here. Right now, to give you perspective, there's about 20% of the business in Medicare overall tied to alternative payment models. So a jump from 20% to 30% just by the end of 2016 is pretty significant.
And something that's interesting about this payment transformation is even without a monumental change in the way that Medicare is paying, we're seeing a lot more Medicare beneficiaries choosing what they call Part C Medicare Advantage plan as opposed to traditional Medicare Part A coverage, that is the entitlement benefit. The issue with Medicare Part C is that there is no settlement mechanism, so they do not make you whole back to cost for that portion of your business, but they will pay you consistently on an interim basis the way Medicare Part A is. It's only Medicare Part A that will settle the hospital back to cost. So as we see more and more folks choosing Part C just because of the way the marketplace is going, there may be a disadvantage in that that's just inherent with the way folks are choosing their coverage.
Yeah, very good point. So that's what we have here prepared. We appreciate the opportunity to present this information for the education in the board meeting here today, and I want to say thank you to management and the commissioners for a very smooth audit process.
Clarification on the last part of the information that you were giving us. We've been watching the proposed changes to outcome-based and the proposed changes to critical access hospital funding. As of now, we don't see any of that penciled in, but we're planning the eventuality so we're prepared if and when it happens.
Yep.
Are we on the right track?
Absolutely. I think that goes back to exactly what Paul was hitting on is while the changes aren't necessarily set in stone, you definitely have to be, I think the word you used was flexible, and definitely need to be thinking out into the future to that point where you eventually, even as a critical access hospital, will likely have to work in this new world of alternative payment models. With the Part C example that you gave and some of the other examples that are out there.
Yeah, one of the keys to doing this, that issue of providers taking on risk. Taking on risk means operating within what they call a capitated environment, where you're getting one set pot of money to provide care for everyone, and once that pot has been depleted, there's no other funds available. Really, the key will be for providers now to operate as if they're only getting a set amount of funds, operating in that environment, still getting what they call fee-for-service reimbursement, and so if there's any excess, then it really is just positive to the bottom line, but you are keeping your operations kind of within the constraints of that cost model.
Does the board have any further questions for Council? Mary and Paul, I really want to thank you. You did a very comprehensive presentation to the Finance Committee, and I'm glad that administration and the rest of the team worked well with you. That's good news for the board.
Thank you.
Yeah, thank you very much.
That's okay. We're working.
I have a brief report for you this morning. It was 1 year ago, if you recall, that we received our Medicare certification for our hospice. So I thought I'd let you know that they're flourishing, they're growing. I always have mixed feelings about saying that hospice is growing, because that means some people are losing a family member, but they're doing it in the best possible way. We've made over 1,000 visits. The program is economically doing very well as well. We've grown the staff. And Carla Jolly has exceeded expectations. She and Dr. Sanders with the palliative care consult service as well, because they've now hit the 250 mark for their number of consults that they've performed. And the secondary benefit of having our hospice services being provided outside of the home health benefit is that our home health has now been able to rearrange its staffing models and its care delivery models, and has been seeing positive bottom lines for the past 4 or 5 months for the first time in a very, very long time. So that full integration of that service line is really performing very well for us, and I know that was something that the board was very interested in following. So I
Did
wanted
you
to give
add
that.
more rehab services to home health, or?
We're in the process of the rehab model requires us to have more physical therapists that we currently have, and in the process of recruiting for those. So it's working as designed.
Our peer hospitals at the Chelan Conference, we talked to a lot of other hospital people, and they have a real problem with those services being money losers. So for us to have both home health care and hospice supporting themselves is really a feather in your cap, and all the organizers that put this together and continue with it. That's really good news for the board. We're definitely ahead of our peer group.
Well, thank you. I think it's largely the result of some really great people. Karen Shano, who's been managing the department for the past 6 months, and Diane, who runs hospice, Carla and Dr. Sanders. It's a great team, and they've been able to get a tremendous degree of teamwork from their staff as well. So when I see them, I'll pass on your kudos to them.
It's really an important service to provide to the community.
We haven't really even marketed it. It's just been by word of mouth so far, with demand that we knew was out there, but we are growing. We had a tiered approach, so if we knew when we hit this point, we'd add relative positions. So the strategic plan was really for about a 3-year growth cycle, and then hopefully it will plateau. What we'd like to see now is for referrals to come sooner in the process, so that people can, and families in particular, can benefit from the service earlier in the patient's decision to go with hospice, rather than our average length of stay. And length of stay in hospice is a good thing, longer length of stay, not as opposed to the hospital. And our length of stay is higher than the national average at 23 days, but we would like it to be 3 to 4 months at minimum. So our next step is to really educate the community about the benefits that hospice brings earlier in their terminal illness.
I would echo that. The education, I think, is really important. Having just gone through this process with hospice, and it was way too short. It would have been wonderful to have had that sooner, but I think there's still that, maybe the resistance to joining hospice sooner, because it seems like it's an immediate end-of-life thing, and where it's very caring and a wonderfully compassionate service.
Thank you. And I think that people don't realize that it's 6 months to a year now. It's not uncommon. And the economic, as well as the support that benefit that it brings, is so much more than people realize. So hopefully that's the next step in our process. Dr. Hansen probably looks a little tired over there, because our ED volumes continue to increase. It's not uncommon for us to see over 80 patients a day. We had a day last week where we saw 94, which was our all-time high for patients. The staff's doing very well, and the patient satisfaction scores are holding, which is no small kudos to that staff and to Dr. Hansen and his physicians. Our team is now complete with Jeannie Sandahl, who's a master's prepared nurse who's got more than 20 years of experience managing an ED similar to ours. And she's hit the ground running to help us cope with that. We're going to have to change some processes, I think, to cope with that kind of volume. But there are worse problems to have. We're anticipating 20 deliveries in August and 20 deliveries in September. So if you're looking at the Whidbey family birthplace volume, it's been a little bit down, but it should be catching up here shortly toward the end of the year. On the quality front, since Teresa's not here with us anymore, I'll be happy to share with you that we're still doing exceptionally well in clinical quality metrics, whether it's surgical site infections, ulcer prevalence, or medication harm. We're doing as well or better than any of our peers in Region 9 for AHA. We have recently, our most recent focus has been on falls. We just celebrated 3 months, almost 3 months of no falls, which you know is a national challenge for patients in hospitals. And the next step in the fall process is we're working on the dementia piece and also on the pharmacy pieces of trying to reduce the number of medications that the elderly especially come into the hospital on that contribute to the falls. But we were able to celebrate the longest period of time we've gone without a fall, which was better than the national average. I encourage you to look at the poster that's up in the hallway on the second floor between Whidbey Family Birthplace and MedSurg. That shows you what the presentation was that Trish Nielsen did at the National A1 conference around reduction of first-time C-sections. It's pretty amazing work and nationally recognized. She's been getting lots of calls about that. Our single biggest challenge continues to be the patient satisfaction on our core med-surg unit, and we have again another set of interventions that we're planning, not the least of which is patient advisory council letters go out this week to the people who have expressed an interest, and it was much more interest than we anticipated. So people will be getting letters, and we'll have an application process and then an interview process. We expect to have between Jerry's preferences between 9 and 10 folks, so that they can have a real voice at the table. And so we have more applicants in that. If anyone from the board is interested in being involved in the interview process or review the applications, we'd be happy to have you do that. And unless you have questions, that completes my report.
What's your timing for putting together the patient advisory council?
We expect the first meeting to be in September,
Okay.
and then quarterly thereafter.
And is that going to include a number of disciplines from the hospital, or who from the hospital is going to be interfacing with them?
I think what we'd like to do is have the members of the council elect a chair, and then have that chair and the council determine who they would like to sit at the table with them. So I will facilitate, but this really is about hearing what they have to say and to help us to improve the patient experience in that core med-surg and ICU area.
So they will be working as essentially community liaison to the hospital, so whatever they hear would be part of the discussion.
Yes. Yes, and you know, obviously when we have folks do this, there are commitments to HIPAA and commitments to other, like we do at Quality, where people, if we're really going to be honest and open about the things that we need to change in order to improve patient experience on those 2 units, then we have to be able to hear what people have to say honestly and openly.
So would the expectation be that if there's an issue that is brought up of significance to alter anything within the hospital, that they would come to the quality committee and present there, and then it would be taken up there?
Member of at the quality committee, we made the recommendation that the chair of the patient advisory council be the community member on the QIC, so they could then bring forward any of the anything that has been brought forward by the patient advisory council, if that's your preference, because QIC is a board committee. So if you concur that that's the right way to go, or I'm sure that they would be willing to use any other model you thought was appropriate.
Thank you.
So they report out to the, I'm just trying to figure out who is going to gather the information that they receive.
It will keep their notes, and the anticipation was that it would go to QIC,
Okay.
and also to, if there are specific recommendations for a given individual or department, that those be acted on very quickly.
And who's going to see that through?
That'll be me.
That'll be you, okay. I think that's where I was trying to go.
Okay.
There has to be one contact one, so that will be, you get another half.
Yeah.
Are there any more questions for Dr. Gibson?
Thank you.
And she's still smiling. Thank you. Dr. Hanson.
Good morning.
Good morning.
So this one's a short one. Dr. James Wine is going to be our first reappointment. He is active staff and he's been recommended for reappointment.
Move to approve.
Second.
A motion is second to approve the active staff reappointment for Dr. Wind. Is it Wind?
Yes.
Okay. Is there any discussion? All those in favor?
Aye.
Opposed? Motion carries.
Our second reappointment is Alan Villander, consulting teleneurology. He's also been recommended for reappointment.
Move to approve.
Second.
We have a motion and a second to approve Dr. Villander. Is there any, for consultant staff? Is there any further discussion? All those in favor?
Aye.
Opposed? Motion carries.
We have a new provisional advanced clinical practitioner who's a PA, Nancy Clark, who will be joining the family practice, and she's been recommended for provisional appointment.
Move to approve.
Second. I have a motion and a second to approve Nancy Clark for provisional appointment. All those in favor?
Aye.
Opposed? Where is she going to be practicing? South?
South would be helpful.
South would be helpful.
The other bit of information, under core privileges, this is affecting the advanced clinical practitioners, so the PAs and nurse practitioners. There was a portion of an EKG special request that required them to have ACLS training to read an EKG, which isn't really necessary to read the EKG. It's necessary for stress tests and things like that, but that's a different part of their privileging. So it's been recommended to remove the ACLS requirement to strictly read an EKG. So we've removed that from our privileging. So that happened as well.
Does that not need to come to the board? I believe that we had those come to the board for approval. So could you
I
bring that?
can ask Molly.
It was a good discussion at MEC around this.
Because we do end up approving more privileges otherwise.
Because I don't think she put it in the packet today.
She did not.
So I'll make sure it comes to the next meeting.
Okay. Thank you.
Yeah, I think that's it. Unless you guys have questions.
No, I think you've been very busy though.
Yes. Making you busy, it's okay.
Yeah.
It's good. The staff's been very engaged. We've got good people working, and clinics are getting more engaged in their roles and taking more responsibilities. So there's good things ahead for the medical staff.
I've been really encouraged by the latest men's staff and MEC meetings that I've attended. It's been a good sharing of information. It's been really positive. And if there are issues, they're brought forward and handled. And it's really nice to see that it's working so well.
It's nice. We're trying to shift our focus a little bit. So people are stepping up to the plate and doing very well.
With the number of people that are now coming in through the emergency department, is it time to reevaluate whether or not there's a walk-in clinic?
We're probably getting closer to that. You know, when I first started in the ER, we saw about 46 patients a day. our average right now is about 67 to 68 patients a day, but it does flex up to 90 plus patients. Yesterday they saw over 90. Last Friday we were over 90. So you start talking about volumes. If you're sustainably seeing 80 to 90 a day, you're talking about a 28,000, 30,000 a year ER visit, up from where we were 17,000 just 2 years ago. So it's been a big jump, and we do need to look at other options for providing access to care for people, whether that's a walk-in clinic or we extend hours of our clinics that we own to include some nights and weekends.
Well, just because you have volume doesn't mean that you have sort of intensity of evaluations and x-rays and all of that sort of thing. So that as you are looking at the number of people that come through, perhaps one of the things to reevaluate is who those people are, to determine if there's a triage that could be done previously, because there's more and more discussion in the community again about some alternative to the emergency department after hours and on weekends and just in general.
And a lot of that can be handled by expanded clinic hours, and that's something that we need to look at again and talk about what our capacity is with those clinics to expand some hours.
Well, the reality is if you're the patient and you want to go to something other than the emergency department because of the cost of that visit, it's more than just expanding the hours.
Jerry, maybe
Unless
that's
it's
something
with
that
the
we can
clinics.
put on for a strategic planning discussion when we have that.
Do we know where these people come from? Are we tracking them geographically?
We can plan to provide you with the report next time. We get we get the information for the emergency department patients by age, by location from zip code, by level of injury or level of complaint. So we can, if that's of interest to you, we can provide that to you.
That would be great.
And one of the things that about the island, that keep in mind that even though we do well from an overall health outcomes perspective, we still have half the number of primary care physicians per capita as what what the mainland has. So that's still still a challenge.
Sure.
Any further questions for Dr. Hanson? No? Okay, thank you. I appreciate that. And I think that is something that we should probably address in a strategic session. Take a look at those metrics, and that will better allow us to look at the overall picture instead of just snapshots. We're on to item 6A. Jerry, the administrator's report.
Good morning.
Morning.
Let me weave in some of my comments and address some of the other conversations that have taken place thus far. Linda shared with you that we are going to be starting our patient advisory council, and since we've had such a robust response of interest in it, we've made the determination to offer some of the people that are interested in that the opportunity to present and be participants in what we're calling a community oversight council. And that will be scheduled initially to meet twice a year, and that will be not necessarily for people who've had experiences in the hospital already, but for those people who find that there are needs in the community that are unmet. And we're going to interface this council with the work that's being done with the Community Health Advisory Board, which is all the survey data. But because surveys are done in every 3 years, we felt that this council could bring us more relevant information, more timely information, since we find that healthcare is such a moving target at this point. 2 or 3 year old data years ago was very relevant, but in this moving target of a healthcare environment, we want to keep our customer voice a little bit more current. So once Linda gets that up and running later in the fall, we will work on taking some of the other individuals who have shown interest and see if it would be appropriate for them to participate in this work as well. Secondly, we have been working on some staff realignment, and the reason we're doing that is you've heard that there's many other changes going on in healthcare. So we're moving some staff around to focus on ICD-10 with a very structured approach to being fully prepared this fall for our implementation. As you know, ICD-10 is the way we document and get granularity on the types of patient care we deliver. In the old days, we might have said we did a repair of a hand, and now they're going to want to know it's the right hand, and it's the little finger, and it's the first joint. So the amount of detail involved in this transition is extremely intensive, and we really felt that we needed to realign our resources to meet that need. In addition to resource realignment, we rolled out centricity in our private practices, and our RHCs are yet to become on centricity, which is our clinic medical record, our electronic medical record. And we also need to take our Meditech electronic medical record, which is our provider documentation system in the hospital, to the next level of optimization. So we've begun looking outside the organization for some resources that can help us get to that next level, because for that level of complexity, we do not have those resources in our current staff. And that is not uncommon for many hospitals who have to go to market